Um, I'm going to focus on where we are as a country in terms of grappling with some of the major public health and health issues and what some of the challenges are, as well as what some of the opportunities are. And then I'm going to tell you a little bit about how the organization that I work for now, Trust for America's Health, is grappling with those thorny issues. I would say that I entered this arena. I've only been in Washington, D.C. now for 4 months, so I still feel like a stranger in a really strange land. My history is as a local health officer, as a state health officer, and most recently as CDC. So I think about a lot of the issues that we're facing, probably similarly to the way that you do, in terms of what do these issues really mean at the grassroots level. And so I'd start by saying while I'm going to be talking about big policy issues, major debates that are taking place about budget, I think it's really helpful for us to reflect on the issues and the implications of those issues in the way that matters. And the way that matters is thinking about them in terms of the impact on the lives of individual people. So I want to introduce you to Brent Edwards. And I'm going to talk about the major policy issues in terms of how it has an impact on her. And she's one of those people who, like 20 million other people, didn't have health insurance, got health insurance through the ACA, and that gave her the ability for the first time to get some really high quality care and treatment for the health risks and the health conditions that she has that are listed there. And of course, you all know that while that is an enormous advance and that's making a difference in terms of her life and 20 million other people's lives, it's not enough. And the reason it's not enough is because the conditions in her life make it hard for her to have optimal health. She can get great quality of care, but if she doesn't have access to healthy food, she can't exercise, she's living in subpar housing, she just can't optimize her health. So clearly our objective is to try to think about affecting her entire environment as well as her access to quality care. And so right now, we've got to be thinking about how do we meet her needs, not just the quality healthcare needs, but also the needs that we can refer to as the social determinants of health, or the conditions in her life. How do we affect those in a period where we're seeing turmoil, enormous turmoil and change from a policy perspective? And with regard to that, I would suggest that there may be 4 different places that we become accustomed to thinking about. How can we begin to address those issues in her life? One of them is, can she get health insurance coverage that's high quality, comprehensive? The other is there a funding for a public health and other sector funding that's going to make a difference in terms of her life? Government funding at all levels. Third, is there some kind of new innovative funding that we can draw upon that's not the traditional kind of funding that just gets approved by the legislature at those different levels? And fourth, are there policies, changes in laws, regulations, administrative changes that'll make a difference? I'll quickly touch on where we are, some thoughts on where we are. I'm just scratching the surface here. In terms of health insurance, I think this is the big fear that we all have, that the health insurance coverage could go away. Ms. Edwards' coverage is based upon her getting subsidized health insurance. She's a low-income working person. Under the House bill that was passed, she would lose that subsidized coverage and she'd get some financial care, but it wouldn't really cover the cost of her health insurance. So the real risk is she'd lose what she's got in the last few years, what she's received in the last few years, that health insurance. We really need to think about that, how we're going to protect her. California, I think, is doing a great job in leading the nation in terms of thinking about that. When I worked at CDC not long ago, we tried to think about how do we embed in the coverage issue, the health insurance coverage, support for preventive services, so that we push the healthcare system as much as possible to be paying for everything it could possibly pay for that was related to prevention, and maybe pushing it into dealing with some of those social determinants of health. Not easy to do. We came up with this framework of thinking in terms of 3 buckets. I won't go through the details of it, obviously, because of time, but I would say that the notion of paying attention to, even with the threat of repealing the ACA, we need to be forceful in terms of thinking about how we get comprehensive health insurance that's paying for prevention and supporting coverage of prevention. We're thinking a lot about chronic disease now, but at CDC we had one approach, just one approach of many that are being taken, where we thought, let's make the case to Medicaid programs and commercial payers that it's critically important they pay for the highest quality health insurance with a preventive focus that was going to make a difference in terms of preventing chronic disease or reducing symptoms. One of those approaches is 618. Raise your hand if you've heard of 618. If you haven't, please go to CDC and 618, you'll see it. The notion there is make the case to the insurers that you can provide preventive coverage that will save money in 5 years or less and have a positive health impact in 5 years or less. For Ms. Edwards, just one example of what this would mean is as she's grappling with giving up smoking, she would get no-cost access to the FDA-approved medications for giving up smoking and counseling as well. We know those work. Lots of insurers don't provide that full coverage. So making the case that they should, even as we're fighting to continue the ACA, matters. We also want to think creatively about what insurers should cover outside of the clinical setting. And there, too, there have been pushes over the years we don't want to let up on, to have insurers pay for evidence-based approaches in community settings that make a difference, or in the home that make a difference. Those include such things as the diabetes prevention program offered in the YMCA, exercise, nutrition, etc., and they include such things as home visits by community health workers for people with asthma to work on the conditions in their home that will reduce those triggers. In Ms. Edwards' case, she got great medication from her doctor for her asthma, but if she's going home to subpar housing where there's mold and mildew in the house, she's still going to have asthma. So one way to pay for that is to get the insurance companies to recognize it's cost-effective to have a community health worker, in this case, working to reduce the risk factors in her home. So that's the insurance front. If we think about, just very briefly, we've seen a lot of talk over the last several years about innovative insurance opportunities, value-based contracting. CMS has recently approved something called the Accountable Health Communities. How many of you have heard of that? So that's a first time CMS is embracing the idea of social determinants of health as a part of insurance coverage, where they're doing pilots now that will involve screening all patients for the social determinants of health and linking to community agencies. Those discussions, we don't have to give up on those, even in this political environment. That's out there. California has received one of those, and we need to make sure we're supporting innovative approaches in CMS, not letting the pressure up in terms of what the federal government can still do. And I've gone to, frankly, a number of meetings in Washington where the notion is clearly, let's stay focused on those, even in this environment, including meetings with people at CMS and meetings with people on both sides of the aisle. So continue with that focus on health insurance, even while we're fighting to continue it. Secondly, there's this category of governmental funding, the funding for public health, federal, state, and local. There we've got some challenges, and this is the proposed FY18 budget by President Trump. We'll see, I believe, next Monday, a fuller version of this. This was released a few months ago with just the bare details, the bare outline of what could be in the budget that would start October 1st. As I said, stay tuned on Monday. It will actually go into the details about CDC, other federal agencies. We'll see more of what is being proposed. But it's chilling, because within that, there was an 18% reduction across the board in Health and Human Services, which, if applied to each of those Health and Human Service agencies, would have a catastrophic impact. This chart shows that it's not just Health and Human Services that was proposed for cuts, but also Such things as HUD was proposed with a 16% cut, education, transportation. Those have a direct impact on Ms. Edwards as well. If she can't get mass transit, how is she going to get to work? How is she going to travel outside of her neighborhood to get to a store that sells healthy foods, which is not within her neighborhood or within walking distance? And obviously, she's got asthma, so if we see a deterioration of the air, as we may see with the cuts you see there in the EPA, her asthma is going to get worse. So paying attention to the federal government and being prepared to talk specifically about how these cuts are going to affect your neighbors and friends, I think will be key. CDC in particular, I would say we're worried about. CDC could lose a third of the total funds that it currently gets, more than a third, very easily. 12% of its funds are tied to the Public Health and Prevention Fund, which is defunded within the House bill. 12% of CDC's budget. If on top of that, CDC gets an 18% cut, reflected in that Health and Human Services budget, that's a 30% cut right there, plus the hundreds of millions of dollars that CDC received that were for Zika end. They were one-time only money. Zika didn't end. So we're facing a potential loss of a third of CDC's budget. Most of that money goes to cities and states. And so we have to talk really specifically about what that potential impact will be. In terms of Ms. Edwards, again, she could be losing the access to a number of different CDC-funded programs, including the REACH program, which works on health equity, and access to healthy foods within her neighborhood. I've talked a couple of times to people on both sides of the aisle who say, you know, if those cuts occur, they can just be compensated for at the state or the local level. Frankly, that's nonsense. What we're hearing across the country is either already significant cuts in state and local budgets or planned ones for the future. Third category of possible funding is innovative funding. There's lots of potential here, and I know people in the state are looking at these or attempting these. They include creating wellness funds with funding from philanthropy or from innovative ways of assessing insurers. There's targeted taxes, for example, around sugar-sweetened beverages. There's pay for success or social impact bonds. All of these are worth continuing to work on. And California, I think, also has been, as a state, you collectively have been working on a number of these. I'd encourage that we need as many different diversified possible funding sources as we can get in a period of uncertainty. And then the fourth category is policy, and by that, again, I mean legal, regulatory, other kinds of approaches that may make a difference. At CDC, we thought of that as bucket 3, or changing the conditions in people's lives. And there, I'll just highlight for you, you all are doing many different things there. But at CDC, we tried to come up with proposals around policy that might work with elected officials who really wanted to see something at the next election. And while we work on things that have an impact that take a generation or many years, we also want to think about things that fit into the concerns of a policymaker that when they run for office the next time they want to see results. So we developed this notion of high 5, health impact in 5 years. The programs you see listed there, which are listed more specifically here, are ones where CDC has endorsed them as they have solid, significant evidence that they work to change health in 5 years or less and have a positive impact on cost over time. Not theoretically, there's an evidence package for each one of these that you can take to your governor, your county commissioners, or mayors and say, look, CDC endorses these and says you can save money on these in a short amount of time. You will note that 6 of these are solidly in the category of what you would call social determinants of health. They're policies that are not even what we traditionally think of as public health, but the evidence is there to work on those. And I would say in terms of Ms. Edwards, just 2 I'd highlight is earned income tax credits, put more money in her pocket, which allow her to do things like pay for healthier foods or join a recreation center. The home improvement loans and grants would assist in terms of eliminating the mold and mildew in her house. That could have an impact in terms of her overall health. So these are directly related to individual people as well as the research showing they work globally. So let me spend the rest of my time talking about what we're doing at Trust for America's Health to work on these issues, and I'll try to be as brief as I possibly can by focusing only on 3 categories of activity we're involved in. These may or may not work for your situation, but I'll just reflect on how we, as a Washington, D.C.-based think tank policy organization, have come up with these. The first one is we decided to focus on a few things where we can be the experts. And this is our swim lane. We really dive deep in these, and we do that while working with our colleagues that are working in the larger picture as well, so that each of us have something of a division of labor where together we can work on these complex, multifaceted issues, but we've got an understanding that some of us are diving deeper and can answer the really specific questions. These are the 3 issues we're focused on. We're the prevention people. So when we work in coalition on the ACA or on health determinants, we think prevention, prevention, prevention. That's our role. We focus in on writing reports and getting information out that will help people work on those issues. So for example, a component of what we're struggling with around the replacement to the ACA is guaranteeing that whatever insurance is required or offered to people has full, free coverage of evidence-based preventive services. Now, in order for us to be making the case, we have to refer to the specific sections within the ACA and how they do that. And so we've written a brief on that because they're complicated. They involve both Section 2713, which has to do with the expansion Medicaid and covers Medicaid requirements, and what you've probably heard a little bit more about, essential health benefits. This is way in the weeds. You don't have to dive deep in that. We'll work on the specifics of that and get that information out so people can focus, that have expertise in other areas on their work. So that's identify key priority issues, drill down, be an expert, but work in collaboration with others who have expertise. Secondly, we've decided to make the impact as concrete and real as possible. And you hear me talking about Ms. Edwards. We're trying never to talk about these issues of policy issues without talking about the people or persons that they're going to impact. And if we can, we want those people in the room with us. Their voices matter. We hear, again, across the aisle, both sides of the aisle, when people hear a story of what someone's life was like and what made a difference, they remember that a lot more than they remember the policy pieces. We've also paid more attention to customizing, to taking complicated information and trying to break it down into state and local specific information. So we've been taking the implications of the policy debates in Washington and developing state-specific packets saying, here's how many people on Medicaid will lose their coverage, here's the benefits they'll lose, if CDC cuts these programs, here are the specific contracts in California that will go away. We've looked at job loss, we've looked at the impact on the economy. We develop those packets and we send them out to the governor's offices and the state health officials and the advocacy organizations. If you'd like to get a copy of those for California, we're happy to give them to you. We've now done a few rounds of those. We send those out in a way that I would describe as nonpartisan, which is to say we just present the facts. And we want them to be received well and taken seriously in red states as well as blue. And so we think that getting the information out will prompt action, and if we don't want them to be received as, oh, we've got a hidden agenda here. We want them to be aware of what the impact is, and we've at least had some indication that that works in that approach works in the more conservative states. And finally, we've decided to focus strategically, and by strategically, what I mean is we want to have an impact. In Washington, we're focused much more on the Senate than we are on the House. Why is that? Because we're just a few votes away from having more than 50% of the votes in the Senate. The House is just more complicated. And we've been able to look at which are the states where the senators have some concerns about the issues that we've been talking about that are on the Republican side of the aisle. Can we work with them? Can we work with those states in a more intensive way so that there really is a possibility of getting some key votes that will make a difference? That means we have to understand who in those states are the people that are on the front lines, and how can we help them? Who are the people that are in a position to have an influence, and what information do they need? I also think that it's meant for us that we have to really struggle to be nonpartisan in our approach. And by nonpartisan, I don't mean that we don't take strong positions. I don't mean that we don't articulate policies that we think are in the interest of the population. We do that, but we try to do it in a way that is that doesn't make those things sound like they're owned by one party versus another, or that if someone doesn't agree with us, they're not smart or they're not caring. So we're really trying to figure out, in this environment in particular, how do you walk that line of strong, principled stances, but ones that you can take that will be perceived as nonpartisan as we're trying to have an influence in those key swing votes that I was just referring to. At CDC, we're doing, at TIFA, we're doing a number of things related to that. And I'd give you the example that we had a meeting not long ago, and Larry Cohn was at that meeting as well as others, where we pulled together folks who work on public health totally along the political spectrum, from people interviewing in the Trump administration for high-level positions to people organizing the resistance to the Trump administration. And we wanted to see, could we get people in a room and actually see if there's some consensus around core public health issues that you could say exist across the aisle, and could we figure out how to have some constructive discussion among people we may need to work together who believe in public health, even though they hold different political perspectives. And we were pleased that we were able to have constructive discussion and understand more of where the potential is. We need to have more of those discussions where we're working with potential allies on important key issues in a nonpartisan way. And I think the last thing I would say is that, we're a Washington-based group, as I've mentioned, and the danger of groups that work in Washington like us is that we're inside a bubble. I would say that's a little bit of a problem in terms of California, too, because you are so admirable in terms of the stances that the state has taken in many different ways on health that it's hard sometimes for people outside of California to understand how they could follow your lead. And so we in TIFA are really working to think about how do we hear the voices of people in Appalachia, in the Deep South, in the northern frontier states, in the Rust Belt, and understand how to hear their concerns, translate our thoughts in a meaningful way, in respectful dialogue. And I really think there's so much that people can learn about California. The more that can be done is really critical as well. One example of the work that we're doing now is we're developing a Mississippi-specific focus project. And the reason we picked Mississippi is we as an organization have been doing policy analysis for years where we rank states based upon how much they are following evidence-based approaches to specific issues like obesity. And California's usually at the top of the list in terms of really best practices. Mississippi's usually at the bottom of the list. And so what we feel like is that it's not helpful for us to just be listing out those things that sort of shame a state that hasn't done the right policy. If we haven't been helpful in terms of working with people in Mississippi, then our work hasn't been effective. So our goal now is to do a deeper dive, working very closely with people, listening to people in the state about how we can be more helpful in terms of getting them the materials, the information, the policy analysis they need. So I guess I would just say in closing, I'm even in these really turbulent times, I'm an optimist. I think that we've got a lot of significant battles on our hands, a number of them I've mentioned, but I think that my experience both in Washington, actually working on both sides of the aisle, and going around the country and meeting with people at a grassroots level have given me a lot of reason for optimism. There is there's a growing awareness, for example, around the country about the importance of dealing with more than just quality health care, but dealing with the issues related to the social determinants of health. The gridlock that I think has gripped Washington, even if it's just temporarily, around what should replace the ACA, keeping the ACA in place, is also, I think, an indication that as people get more specific in terms of what the replacement would be, they see the dangers associated with risking the loss of insurance, high-quality insurance, to the 20 million people. So it won't be easy. It won't be easy for us to work at the federal, state, or local level, but I think there's reason for optimism. There's reason for our, but I think it will require our collaboration, our thinking strategically, our understanding the lessons, our being able to talk across the aisle and across states. I think if we can do that effectively, it's possible for us to take advantage of the opportunities and beat back some of the challenges. Thanks.